Welcome, everyone. I'm glad to see everybody here. I'm going to introduce our speaker. Dr. Kate Herster Dr. Kate Herster is going to be speaking to us today. Dr. Herster is an investigator at the VA Puget Sound Center for Innovation for Veteran-Centered and Value-Driven Care and assistant professor in our department. She also provides clinical care on the VA PTSD clinical team. She received her PhD in clinical psychology from the SDSU UCSD Joint Doctoral Program, where she also received her master's degree in public health. Her research examines improving health behaviors, especially among veterans with PTSD. She's published nearly 50 peer-reviewed papers related to these topics. She is currently in the final year of a VA Health Services Research and Development Funded Career Development Award focused on developing and piloting MOVE plus up UP, a weight loss program she developed to address obesity in veterans with PTSD. She is awaiting an official funding decision, but will likely be studying MOVE plus up in a VA R01 level grant starting this winter. She has increasingly seen the importance of broadly communicating with various stakeholder groups and the public to advance veteran and broad population health, which will be the topic of today's presentation. The department would really appreciate all of you completing the evaluations for her talk today. And they're going to be collected. They're on the tables. Please don't forget to fill them out. Thank you, Dr. Herster.
Thank you so much for that introduction, Dr. Ram, and thank you all so much for coming today. I'm really excited to talk to you about the work that I've been doing to broadly communicate about the research I conduct with various groups and the learning that I've done in that process. I'm hoping I can share with you so that you will join me ultimately in doing more of that, more science communication. I want to note right off the bat on my home slide, the sort of standard home slide, that in addition to roles you would expect to see there, my affiliation with the university and VA, I've also included a role advocate, and that is in my personal role. And the reason for that is that particularly when I get to the end of my talk where I'm talking about how to communicate about science with the public, I do don the hat of advocate in some of those activities, and I think that's an area that people find particularly confusing to navigate, how to bring your professional expertise into the public sphere without breaking laws and making sure there's no conflict of interest. And so I'll talk about how I've navigated some of those issues as well towards the end of my talk. Ultimately, with the goal of increasing our impact on public health. So my goal for today is to set the stage for what I mean when I am talking about science communication and why we should do it. I will use as a vehicle for describing this 4 examples of how I've worked to communicate about my work to the broader community. A veteran, an academic presentation I made to a veteran patient group, how I've worked with VA clinicians and healthcare system leaders to get their input related to implementation using visual media. I've done some writing for the public using op-ed, so I'll describe one of those experiences. And then lastly, I'll talk a little bit about legislative advocacy that I've engaged in. And what I hope will come from all of this is that you will leave with some specific strategies that you can apply to your own work, whatever that is, whether you're wearing a clinician hat or researcher hat or administrative hat, that you can see how some of these principles could apply to you communicating about your work more broadly. So really, ultimately, an invitation to you to join me in doing this work. I also will be interested as I go along during the talk to hear about what you're already doing in your daily work to communicate more broadly. So to set this stage for the talk about what science communication is and why focus on it, I will be using throughout the talk this model. I will be building upon it, but I want to orient you first to the model. So in communication of any kind, we have a message that we want to convey. We deliver that message by some medium and ultimately want to have an outcome from that, right? And in this case, what we're going to be talking about today primarily is the impact on public health that we might desire. So what, in science communication, what are the dominant standards for how we communicate about our research? What was that?
Academic papers.
Academic papers, absolutely. Anything else that we do? What are the messages of those academic papers? Like what's the content?
Research findings.
Yes, right. Research findings, our methods, maybe our justification, the implications of that work. And that's really what goes into primarily our science message that shows up in a peer-reviewed publication. The other place that we typically communicate about our findings are conference presentations, talks like this in an academic setting. But it's the primary medium. And who typically receives those messages? Other scientists, right? Yeah, you all. So other researchers, absolutely. Hopefully, in some cases, clinicians who might be able to put that work into practice, perhaps healthcare system leaders. But what we know is that oftentimes, even the other researchers and clinicians who might receive our science messages probably already are fairly receptive. They're sort of interested in the topic, they receive the message, operating in many ways like the echo chambers we hear about in the sort of, rest of the world. And this is probably one of the contributing factors to why it takes so long to implement research discovery into practice. We know, the often cited statistic that it can take up to 17 years to implement research findings into practice. And that's actually for a very small minority of research at all. And so I hope we can see that this is an insufficient way of getting our science messages out there. So the other question to ask, right? So we've talked about a little bit about the audience and set the stage for who receives our messages currently. Who else might need to receive our messages in order to amplify the effect? The public. Mm-hmm. Politicians. Policymakers. Yep. Any other thoughts? Some of those are listed here in this audience segment of this model. In addition, and partly how you might reach those people would be using the media, community organizations, health advocacy organizations, and certainly the people who are decision makers in our healthcare systems as well. So these folks, if this is our audience, where we want to translate our science messages into action, are they going to be able to read all of our papers and come to our conference talks? I see some heads nodding no. And so what do you think would grab their attention? Again, we're thinking about the message and the medium here for how we deliver those messages. What are some ideas about how to reach those folks? Social media, absolutely. Any other thoughts? Well, you will have some ideas by the end, at least today. I've listed some of the mediums here: conversations with people who are invested in the topic, social media is on there, video, print, etc. I think the thing that I really want to point out here, though, is that the standard stuff we put into peer-reviewed publications is probably overwhelming and too much detail for those audiences. And in addition to that, is probably not going to captivate their attention, right? And we know from the science communication literature that folks are going to be more captivated if there's a story, a personal interest element. And so you'll see here throughout the talk, hopefully you'll hear how I've worked to create a more data-driven story that we then thought about how to deliver through various media. So what are the things, if we agree, I think that there's some buy-in in the room, if we agree that it's important to do this work, what are the things that for you get in the way of communicating to these various audiences? Health literacy of the audience. I'll definitely be talking a bit about that. Political bias against the findings. So sort of receptivity to the message in the audience. Absolutely.
Telling people what they should do based on our very special expertise in providing those mechanisms.
Telling people what they should do without, I'm repeating this for the folks who are, not here, but that's absolutely right. We often have messages, that's another issue about receptivity, but also about the ability to translate what we suggest and recommend into action. Absolutely, these are really fantastic barriers, some of which I will hopefully help you overcome specifically, and think about how you can do more of that going forward. Some other barriers that I've heard people mention to me are lack of time, like in our busy schedules as clinicians and researchers, where to fit this in as a priority, particularly given sort of incentive structures in academia, just basic know-how. And one thing that I'm going to touch on a lot, like I mentioned earlier, is this sort of murkiness of the line between professional and personal identity, and how to navigate that from an ethical and legal standpoint. That being one of the biggest barriers that some of my colleagues have mentioned over at VA. So now I'll dive into my series of examples that I hope will help you think about how to overcome some of those barriers to science communication. I've done a lot of learning in this process. You'll hear about some of my missteps, as well as some of the, I think, successes in doing this work. And so I'll dive right into that. So in my mind, one of the most important groups that we communicate about our science with is the patients, families, individuals who are directly affected by our research, who would be directly affected by our research. And what are the various ways that you are communicating with patients and families about your work? If you see patients, or could be, research participants as well. Handouts, giving them handouts with what's on the handout when you give it to them. Patient education, absolutely. Like, here are the sort of pros and cons, for example, in a shared decision-making handout that could help you weigh a health decision. Or here's what we recommend about this particular health issue. There are many ways. I mean, as a clinician myself, I do a lot of that, of helping patients wade through the sort of, here's the evidence, here's what we know, here's what we don't know. And, you mentioned health literacy as such an important consideration in that. And it's a complex discussion, and sort of depends on your own your perception of the person's health literacy, how that goes. I'll talk a bit more about that, but there are lots of other ways that we talk with patients, their families, research participants. I wanted to highlight one particular example I think is really powerful, which is in VA, and I think many other settings now too. We have patients who serve in our case, veteran engagement boards that consult on our scientific plans, findings, how to disseminate the research. And that has been really powerful as a tool for making our research more veteran-centered. And in order to have that work, those veterans need to have a certain understanding of scientific processes, grant writing, how that whole endeavor works. And so it's required a lot of sort of bidirectional communication about that. That's just an example I wanted to highlight. The example that I'm going to talk about from my own particular work, where I did a lot of learning about this, is I was invited by our Seattle VA's General Weight Management Program last year to give a presentation to their monthly alumni group, where they have about approximately 60 veterans show up each month. And sometimes the group operates as a support group, and sometimes there's an academic talk where someone comes and gives some weight management related presentation to them. And so I was asked to come give an academic talk to the group about my research. As Dr. Ram mentioned, I've been studying a weight management program that's specifically tailored to veterans with PTSD over the last couple of years. And so I was invited to come and talk about that research to this broad sort of weight management alumni group. And since I'll be talking about that research, how I communicated about the research, I want to briefly describe Move Up, which, as Dr. Ram pointed out, is, a difficult name. Maybe the marketing was off on that one, but at any rate, in Move Up, it's a weight management program we've developed for veterans with PTSD. It's a 4-month-long group-based intervention that draws on standard behavioral weight management principles, but also has elements that address PTSD-specific barriers that in our research we've found has really gotten in the way of traditional weight management programs working for folks with PTSD. Just as an example, veterans with PTSD experience hypervigilance, as many of us likely know, and that can get in the way of being physically active in their communities. And so our intervention targets that symptom as a way of having them be more active to help with weight loss. We piloted Move Up among 44 veterans and in group cohorts, because it's a group-based intervention, and developed the intervention over time. And ultimately, we have a paper under review that's describing that process currently. So when I was developing my talk and thinking about how I would communicate about that study to this veteran group who had no familiarity with the intervention, many of whom did not have PTSD, I thought about how I would apply science communication principles to engage the group and have it be meaningful to them, since the study may not be directly relevant to their experience. And so I thought about all of these science communication issues, right? What is my message going to be? How am I going to communicate it? Well, I decided, because I'm an academic, I, of course, just defaulted to a PowerPoint presentation. But in thinking about preparing that PowerPoint presentation, I did consider that, health literacy issue and presented less of the details that I would typically present at, say, a conference. Like, there were no p-values in my presentation. I didn't include an exhaustive list of measures in my statistical analyses, and instead prioritized for my message the data-driven story. What were the qualitative experiences of the participants in the pilot, and how would those be relevant to the people in the room who, as I mentioned, didn't necessarily have PTSD? So just as an example, I really thought about, okay, I want to engage the group. I want to generate discussion right off the bat. And this is a sample slide for how I kicked off the presentation to get discussion started, asking them about how their mood related to physical activity and eating, and ultimately weight management, how those things were related. And, I sort of saw this as an icebreaker discussion generator. And what I realized very quickly is that despite being billed to me and to the audience as an academic talk, it quickly moved into being more of a clinical interaction. I'd opened up this discussion to talk about emotions and health, and vulnerable sharing, commenced. And luckily, I am a clinician and a psychologist, and I was able to navigate that line sort of on the fly. But it reminded me of just how meaningful those even academic talks can be to patient groups, even if that's not sort of how they're billed. The other thing that it allowed me to see, though, is that during this discussion slide, which I'd probably allotted, 2 minutes for, 15 minutes in, the group kind of got derailed and we got off track. And what people started doing was spontaneously sharing about their challenges and successes over the past month. This wasn't, built into my timeline. But after each person shared, the whole room of 60 veterans erupted in applause. And it was very powerful to observe. It's not something that I'd ever seen in a group setting before as a group therapist. And as a result of witnessing that and the power of that, have subsequently integrated that into our intervention that we were, still developing at the time. So in addition to being an academic talk and clinical experience, it was a sort of process observation for me. This is how I presented the findings of my pilot, which we could probably pick apart in many ways. But I will say that one of the key considerations was I didn't want to overwhelm the audience with lots of details about the measures and statistical findings. I wanted to summarize and synthesize the findings in a very simple, straightforward way, sort of assuming, and I will acknowledge a faulty assumption about what the audience would want to engage in regarding the science. And what happened immediately when I presented my findings is that people in the audience really wanted to know more about what we had measured, how we'd measured it, at what time points, and should we consider measuring things differently in the future. And these were folks who had no familiarity with my study prior to me presenting, but had really rich, meaningful feedback about the science. And in addition to that being helpful for me as a scientist, it also gave me the opportunity to observe how empowering it is for patient groups to be engaged meaningfully around science, and challenged my assumption about, at least made me think about even more carefully about what assumptions I make about what people will be interested in learning about science and what details about that process they'd want to hear. So to summarize this particular example, it's clear that even though I went in with my science communication hat, thinking about the best ways I could communicate to the audience, I had overlooked what is really a powerful tool in all of this work, which is setting it up so that it's really an opportunity for bidirectional communication about the issue. And what happened when I allowed that to be was informative to my research and empowering to the people in the room, and highlighting this importance of conversation as a medium. So now I'm going to move on to the second example, which is how to communicate with stakeholders, which is a very broad term that is applied in many, many contexts. But what I mean when I say that in this particular presentation is folks probably other than patients and families who are invested in the issue, either because they are going to be affected by it, say a clinician who would have to roll out an intervention, or a decision maker who is a healthcare system leader, for example, who would be in the position to support an intervention being implemented or not. So what are the ways that you in your work communicate with stakeholder groups, or think that it would be important to communicate with those groups?
Well, personally, I think the best thing that's out there right now for stakeholders, non-professionals, has everybody heard of this American Life 10 sessions?
Well, I will be talking about that at the end of my talk. So yes.
This is for people to actually hear a journalist tape her therapy experience and see what is really involved in it after, I don't know, 30 years of going to random therapy and 2 weeks and 10 days, she's better. And to my mind, that's the best thing we've got for PTSD, but maybe for any evidence-based.
Thank you.
Because a lot of, I'm in the PTSD work, but a lot of regular people hear that and suddenly, now I finally get what you're talking about, what it really is, how it actually works. And so I think that was an amazing opportunity.
Absolutely. So thank you for mentioning the 10 sessions, This American Life episode. And I will be talking about that a little bit more at the end, but I agree it was a very powerful tool for public education and many other positive outcomes. So there are many ways that it's important to communicate to stakeholders. Again, this broad term. Some ways that I've observed this playing out is in VA, for example, when we have a study that comes out, people even invested in VA who are running, national programs. It's really important for us to sort of digest the findings for them. And so we're in the habit now, if there's a policy, healthcare policy relevant paper, putting that in a policy brief form so that it can be shared with operational leaders in VA. Really, this work of communicating with stakeholders is a key part of any learning healthcare system. And the example I'm going to give from my own work, I hope illustrates that point. So when we were done with Move Up, our intervention pilot, and we had sort of settled on our intervention structure and design, we then wanted to go back to our stakeholders, who in this case we considered clinicians and healthcare system leaders, to ask them to anticipate any implementation related barriers and facilitators to ultimately implementing Move Up in the healthcare system. Something that is an ideal activity if we want to have our interventions actually be picked up in the clinical setting. And so we were going to do this in semi-structured interviews, using qualitative research. And the people that we wanted to talk to, our audience, was folks who were not familiar with Move Up yet, but who would be in a position to either deliver the intervention in the future or support its implementation into that setting. So because they were naive to the details of the intervention, we needed to really think about what is our message, what do they need to hear to learn about Move Up so that they can comment on implementation, and how are we going to inform them about that? What's our medium going to be? So our first plan, which I will acknowledge up front, we deserted, was to provide them with a handout, which is kind of standard fare for our work. We give our patients handouts, and I thought I'll just give the providers a handout that details the most important components of the intervention, and then ask them our questions about implementation barriers and facilitators. And as we were preparing this to do our interviews, we piloted them and immediately got the reaction that clinicians who are overwhelmed with visual information all day long would not enjoy this experience. And also, from the handout, we're not able to really visualize and picture the intervention. And someone asked, how could you instead really bring this intervention to life so that the providers can really understand it? And so what we did was we decided to work with our local VA medical media to create a 6-minute video about Move Up. So that's as brief as we could get it, 6 minutes, thinking that would be about the span of attention. And in coming up with the video, though, we then had to, of course, ask ourselves what details they needed to know about. And, as being the person who mostly developed Move Up, I was enamored with all the content that's in the intervention, but realized that these folks didn't need to know about that for commenting on implementation. Instead, we really focused on, we gave a little bit about the content, but primarily focused on things like staffing and safety procedures and the logistics of the intervention, where this is held space-wise. And that was, allowed us to get what we needed from our, interviewees. What this required, medical media at the VA does provide this sort of technical filming and editing work for free, which is a fantastic resource. But I had to learn sort of on the spot how to screenwrite and direct and staff and do voiceover work, for this 6-minute video. And it was, a really fun, ultimately, process, but certainly one that involved some learning on my end. We mostly staffed it with volunteer actors, other VA staff who we compensated with chocolate bars and tea. But it was a really fun project. And as I mentioned, we focused on the implementation relevant details. The other thing, though, regarding the message that I wanted to point out is, again, we considered health literacy. In this case, most of our stakeholders are clinicians, many of whom have conducted their own research, so they have high science literacy, high health literacy, but nonetheless, we worked to strike a balance between providing them with, sort of just the right amount of information so that they could comment meaningfully on the intervention and whether it could be brought into their setting without overwhelming with a bunch of methodological details that they didn't really need to know about. As a result of our movie, we've conducted our interviews, and sort of the summary about their sort of reaction to the approach, the video approach, was, I get it, I understand what Move Up is about, and as a result of that, they were able to provide really informative, practical feedback that we've now been able to integrate into our plans going forward. I would say, sort of summarizing this example, that it certainly illustrated one of the classic recommendations in science communication, which is the importance of having a data-driven story, and ideally presenting that visually or using other media that can be sort of quickly and readily absorbed by the audience. But it also demonstrated yet again that the importance of approaching science communication in a way that allows and facilitates a conversation between you, the person who holds the science message, and the audience, because really there is this bidirectional sharing that can occur in optimal science communication that is so meaningful for both parties. So now I'm going to move on to my final two examples, both of which are related to communicating about science with the public. And you can see every audience here is highlighted because we are all the public. Each of these settings could be considered, right, operating in the public sphere. What are the ways that you are currently or think, and we've heard some good examples, I think, already about some public communication about science. What are some additional avenues, approaches for communicating with the public? Yes.
Have an educational session and bring all of the different people together, the stakeholders, the patients, clinicians. Preset goals, set objectives, what you want to accomplish.
So a panel that really brings all of the parties, patients, clinicians, and so forth, all together on a panel. In what setting? Where is that held? Is it here at the university or? Mm-hmm. Absolutely. So it could be held here at a medical setting or in a community setting. Absolutely. Yes.
Like a campaign about a certain topic on an annual basis. Meet the advertisement for it, to bring together activities.
Yes. So campaign, health fair sort of event. Those are great. All great examples. So some additional examples, and you can see I've sort of biased towards media just in my slide for whatever reason, but the university puts out press releases when we have studies that are coming out, interviews with the press regarding breaking research findings, podcasts. We heard an example already about a great podcast. Those are emerging as a really important vehicle for health communication. Community events. One thing I did want to highlight was the role that I do think social media plays a really important role, and increasingly so in health communication, and it has its dark undersides for sure, but academia is showing up more and more in the Twitter space, and one of the great things about that is that I have found it's a wonderful way to connect with colleagues I wouldn't really even know about otherwise, unless I did a PubMed search. And it actually brings some of those interactions with colleagues or potential colleagues to life through real-time interaction. It also democratizes access to information. So if we want to communicate about a health message to the public, it's one way to do that. And lastly, I think one thing I've seen really powerfully on Twitter is that it gives you an opportunity to amplify the work of others. So, people who may not have as big of a platform but have a really important health science related message, you can retweet that, you can promote that message, and so I think it is emerging as a powerful tool to be approached with caution as well. So the first example I'm going to describe is the process of writing an op-ed, so an opinion piece. I've published a few of those, but I'm going to highlight one that in particular I think highlights some of the key things that I would want to know about how to approach writing an op-ed if I hadn't done it yet, and I'm still learning. So the op-ed that I'm going to talk about is one that I published along with 3 other colleagues this past summer. And our message was pretty straightforward. I'll talk a little bit about the backstory in a moment, but essentially, you may know that Tobacco 21 laws are sweeping the nation right now. What those laws do is they ban purchase of tobacco products if you're under the age of 21, and they have a lot of promise for, in particular, preventing young people from starting to smoke. And so they've been passed in a number of states. Washington, D.C., Washington State now has a Tobacco 21 law. Unfortunately, many of those laws exempt military populations. And as a VA health behavior researcher, I find that very disheartening because I've done research to show military populations are much more likely to use tobacco products. So they're already at a disadvantage, and then they're exempted from many of these state laws. And so in our op-ed, we made the case to end those military exemptions and voiced our support for expanding Tobacco 21 legislation as well. And so I'm going to walk you through the timeline of how this played out, because it's quite a different timeline and process from our typical writing that we do in science. And so where this all began was just in April of this year. I attended an op-ed project workshop at an academic meeting that I attend every year, the Society of Behavioral Medicine, and attended the workshop, learned a bit about how to write an op-ed. The op-ed project leads trainings, all over the country. It was really valuable. And later that week, I noticed a Tobacco 21 poster, out walking around Washington, D.C., and spoke with a colleague later that night at a social and said, how does this law affect military populations? So it was just a conversation that, we quickly consulted Google while we're at this event, and come to find that military populations are often exempt. And lo and behold, we decided to write this op-ed. And so immediately, well, not immediately, about 6 weeks later, we had a conference call and started writing the piece. And quite unlike our typical academic writing, we were targeting about a 600 word count for our complete message from start to finish. That has to include counter arguments, kind of like the limitations section. You have to acknowledge in any op-ed sort of the other side, the arguments against what you're arguing for, all captured in a very short amount of space. In fact, Seattle Times op-eds are more like 400 words, for example. Many of them. And as part of this writing process, we also identified our targets, so what media outlets we wanted to submit to, and worked with all of our media relations groups. So that's another key part of this process I want to highlight, which is that we have a really valuable resource in the UW newsroom for doing this kind of work, whether it's an op-ed or others writing for the public. And they're also really important to get to get approval for using any kind of university affiliation in your piece, and incorporating the appropriate disclaimers and so forth. So we did all of this in June, and then because it's important to tie any op-ed to a really sort of hot off the presses news topic, we decided to tie the op-ed to a memo that we knew was going to be put out in July from the Joint Surgeons General from the Department of Defense and the US Surgeon General regarding military tobacco use. So we decided, okay, we've got to get this op-ed completed by the beginning of July, and started to submit to our various outlets. Well, first we submitted to the New York Times, and I can tell you right now, it did not get published in the New York Times, and had our list from there. So we gave it a few days there, then submitted to the LA Times, found out they weren't going to publish it, and then submitted to a local paper where one of our authors lives and that has a really strong military presence, so a really relevant message to that setting, which is San Antonio. And all of this happened in a matter of about 10 days to learning that the piece would be published in the San Antonio paper. And so very, very rapid timeline, right, compared to what we're used to with a peer-reviewed publication. And that highlights one of the key things and that I think is really important to remember with doing this work, is that along the time while we were writing our piece, we were also thinking about how we would disseminate the message after hopefully it got published. Like, who were the key healthcare organizations that would need to hear about this message? Who were the key policymakers who needed to know about it, and so forth. And so we had a post-publication dissemination plan ready to go as well that we had to, sort of implement right away, because the piece came out about 5 days after we found out it would be published. And sometimes it's actually more like half a day that you have to get that together. This also highlights that if you're going to undertake doing this kind of writing for the public, if you have an idea, start writing it now. Have a drawer of projects that you want to get your message out to the public about. And then when you have a new research study or there's news that comes out that's really relevant, then you'll have all of your UW approvals in place, your VA, public affairs approvals in place, and your message really well crafted when that news or research study comes out. So, really highlighting that if in this conceptual model, if your first target audience is the media and the people who read that paper, just like all of this other, work, it's probably not sufficient to stop there, that you also want to think about how you can reach these other audiences that are going to actually translate that message into action. So the final example I'm going to talk about is working with public policymakers. Others in the room mentioned that as a particularly powerful avenue for doing this work, and I would agree. I think policy has some of the biggest potential for sweeping public health impact. And so I went. This is a group of us who went just about 2 years ago to Capitol Hill to advocate to senators and their aides regarding a couple of key behavioral medicine related policy issues. And again, went with my Society of Behavioral Medicine Professional Society. Our message, Society of Behavioral Medicine gave us 3 key policy asks. They did not let us kind of, run off the rails with whatever issues we thought were most important. They had policy briefs that they'd produced that we were to present to aides and talk about. But again, though, back to the data-driven story, that was the sort of, foundation we spoke from, but we also were asked to bring in our personal perspective as constituents. And I think that's really important to highlight, because in doing any of this work, at least from the standpoint of the university or VA, you're doing it on your personal time as a constituent. And that was certainly the case with me in this activity. But that's also what legislators want to hear. They care more in many cases about the personal interest, just like all of us. So I want to highlight some of the approvals that are required to do this work. I think it's really important, if I'm encouraging, even implied, to do legislative advocacy, that there are laws that you need to know about that prohibit approaching that work in certain ways. So for example, you have to represent your personal perspective rather than the views of the university, and that needs to be really explicit in your communication. And you hold whatever expertise you hold. You can't get rid of that as a human being, but you have to speak from the personal expert opinion rather than the research you're conducting, for example, at the university currently. The reason for this is that you can't use your professional title by law or resources for personal gain, because of the conflict of interest there. And so to learn about all of this, I got great consultation from administrative staff and lawyer teams and ethics folks, for me, primarily from VA, but that exists on the university side as well, ultimately resulting in me doing this work on vacation. And again, from my personal perspective. But I put this up here, but I don't want it to scare folks away. I want it to be here as so that you know, this is the list of the things that you have to do to make this happen. And it was worthwhile. It was incredibly meaningful to get to go to Capitol Hill and interact with the people who are enacting laws that affect our patients, our families, you know, our lives. In fact, I want to point out that I've continued doing this kind of work, and actually at 1 o'clock today, I will be starting a vacation to march to City Hall to participate in the climate strike and to go meet in City Hall with folks who are having a special transportation meeting with the City Council. Again, I consulted with, you know, the legal folks at University of Washington to get approvals to do that. I'm using my personal time, and I wanted to highlight that, you know, as a person who lives in Seattle, who has this public health background, it feels really essential to participate in these activities. We can do it, but we just have to know how to navigate the ethics and laws around those things.
How can that be personal gain?
So that's another question probably for us to ponder. It's personal gain in that it has a personal impact, right? I hope, for example, I will be transparent. The reason I'm showing up at the transportation meeting is as much because I think it has a public health impact as I walk to work. And, you know, I see the need for more infrastructure in our city to promote that activity safely. And so, you know, I guess it does have a personal gain potentially. So it's worthwhile for me to engage in that. But I do think, you know, to your question, these issues are complex, and it actually brings me to one of the sort of final points I wanted to make about this, which is that, you know, as I noted a moment ago, we are researchers, we're clinicians, we're healthcare system leaders, we're also the public. And I think what I've heard from colleagues is that this stuff I'm talking about here, the boundary between personal and professional, is one of the things that gets in people's way of doing this kind of work, advocacy work. And I think it's important to acknowledge that we all wear all of these hats, probably at some point. I'm a researcher, I'm a clinician, sometimes I'm a patient, sometimes I'm wearing my mom hat because I'm a mother, and I live in a particular neighborhood, I have particular values. That's the case for all of us. And we bring, of course, those identities to the research that we do. And inevitably, we bring the research that we do to whatever we engage in on the personal front. And what I think that makes this stuff murky and uncomfortable in some cases, but I think it's worthwhile because I have found the most sort of powerful experiences I've had in my professional life have been where I'm sort of activated to engage around something because I care about my patients, but also because it affects the communities I care about beyond those groups. And so, you know, recognizing that this is complex and requires sort of examination, reflecting on giving this talk, it made me think about how we navigate that complexity, and reminded me that as researchers and clinicians, we draw on things like consultation with our colleagues, sometimes with legal, sometimes with leaders to navigate complex patient care issues or research conundrums. And we have to evaluate our biases and motives. I mean, those are things that we're doing anyway in our work, our more standard professional activities. And so it's possible. And to do this, and those are some of the strategies that we can draw on to navigate it. So with that, I want to close with some Talking Science dessert, which is about amplifying this powerful example that you brought up already that came out very recently on this 10 Sessions episode on This American Life. So on the same department email where the announcement about this talk went out, it was highlighted by the department. And as you mentioned and described, the session is 1 hour long, and it describes, or it it captures Deb Kaysen, who used to be here giving 10 sessions of cognitive processing therapy for PTSD to a journalist who experienced sexual assault. Sorry. It's a very powerful episode and moving just talking about it, excuse me. This involved ethical consultation and legal consultation. It seems like a huge project that required a lot of logistics and a lot of effort and a ton of vulnerability on both of their parts. As a clinician who provides CPT every week, it was incredibly powerful to listen to, you know, just to feel validated, like, whoa, this is the work I do every week. This is incredible to have that reflected back. But also, you know, I first learned about it not from the announcement from the department, but I was pushing my kid on the swings with another mom and someone who has no experience with psychotherapy, and her mind was blown about what psychotherapy can look like and what it can do. And it just took me by surprise, like, wow, yeah, the public doesn't necessarily know what we're doing. And in that email with the department announcement, apparently this episode has been listened to over 3 million times. And I've already heard patients talking about this episode, how it's changing their perspective on this treatment. And to think about what something like this, that did require a lot of effort, but it's 1 hour science communication, to think about what that could do to reduce stigma of PTSD and people getting care for PTSD, but therapy in general that's high quality, is just amazing. And so I wanted to leave you with this example of just incredible, vulnerable, impactful, potentially science communication, to think about how you might do this work yourselves. So in closing, you know, I've described some of the challenges of doing this work. There are logistical challenges. It's complex sometimes. There's no obvious incentive in our academic, you know, promotion structure, for example, for doing public-facing writing. And there are unintended consequences like conflicts of interest that it's really important to anticipate and try to avoid. But I would argue that the benefits far outweigh the challenges. It often gets to tap into creativity we don't get to tap into a lot in our work. It gives opportunities for real, meaningful communication with other audiences that we don't typically connect with, and hopefully ultimately has a broader impact on public health. So with that, I invite you to join me in this journey of science communication, and want to thank the village of people who have helped with the research that I've been conducting, as well as the science communication work. And I hope you'll join me in communicating about science to the public to improve public health. You can email me here if you would like to pick my brain further or share ideas, have a conversation. Feel free to email me. And thank you so much for your time today. Any questions? You're welcome.
The paper in which it was published, did readers have the opportunity to comment?
Yes, absolutely. Readers had the opportunity to comment. And I used to avoid comment sections on those sorts of things, but actually now I look at them for other people's writing as well, just because I think it's an important part of that conversation that occurs. Yeah.
Just as a reminder, this spring I had an op-ed piece published on a fairly bland topic. And I read 1 or 2 of the readers' responses, and I thought, oh no, no more, thank you.
Oh,
And I was told by colleagues that there was a whole slew of rather vicious comments on a topic that was fairly bland and inoffensive. But it reminded me that this is something to be prepared for.
Yes.
And if you are going to be thin-skinned about it, which I think is perfectly reasonable, because after I did this, I decided maybe I need to see a dermatologist as my skin gets I really didn't want to do this again, to open myself to such unpleasantness. So it's something
Thank
to
you.
be reminded of.
I'm so glad you mentioned that, Dr. Ram, because yes, depending on the degree of vulnerability that you have undertaken in your writing, like for me, writing about Tobacco 21 legislation was less vulnerable than some of the other writing for the public I've done that has more personal relevance. And yeah, you do have to decide, am I going to dive into the comments? It opens up a line of communication that can be also very vulnerable. So to be prepared for that and figure out your own skin thickness.
And I will be thinking long and hard before doing another op-ed. Because essentially you're taking position, and there are gonna be people, and it can get pretty intense.
The public can be absolutely untrammeled. The public can go wild.
And it's
There's
not
a lot
only
of,
the public.
a lot of rage
Yeah,
under the
I agree.
surface
I
that a
think
lot
it's
of
really
people
good to
have.
put out there.
Mhm.
You take a public position on something, where it's even possible to have another, you know,
Yes,
you're venturing into a world of completely.
you're opening up that communication, absolutely.
You have to plan ahead.
Yeah. Well, now that I've cried in front of all of you about the CPT episode, I mean, you know, it's I didn't even anticipate that, but it's this thing you have to weigh, like how vulnerable am I willing to be, and what will that hopefully achieve that's positive. You know, are there people who respond to an op-ed that it's worth it to hear their perspective back, to wade through all of the more painful comments? These are tricky issues, and issues frankly we don't often have to face when what we're talking about is publishing a peer-reviewed paper, where the formal comments back approach is pretty constrained. So we're not, you know, in many ways not used to that kind of feedback, and it can be very hard. Maybe worth it though. Yeah.
I was thinking earlier in this talk about like how would I encounter, like if someone wanted to reach me, you know, as a doc, how would I encounter information? And I was thinking, well, I get J-Watch and I get the Carlap report, which is for psychiatry. Like I get curated resources.
Yes.
And I'm not going to see academic papers unless I'm looking up a specific problem for a specific patient. So there's that kind of curation, and then there's like the curation of like This American Life or New York Times Seattle Times.
Yes.
And I don't know, I was just thinking about like it feels like there's something to that in terms of like how you actually reach people if you want to reach, at least I guess clinicians, but certainly the public too. Like those kinds of like, there's so much information now that things have to be curated.
Yes, no, I think that's really important, both from how we receive information and recognizing that, right, like if I'm subscribing to those two papers, which I do, you know, that funnels information to me in with a particular lens. And likewise, you know, I subscribe to JAMA alerts and, you know, a few other journals, and that curates what I receive as a clinician and researcher. And likewise, that's how everyone is sort of, you know, of course, having to wade through the information, you know, overload. And so, yeah.
Targeting some of those kind of people, like a J-Watch or Carlap report or something, like shopping some message to them might be important.
Absolutely. Yeah, that's another great audience, and for them to recognize also the power they hold in what they communicate. So, yeah, thank you.
From 20 years of experience being chairperson of the Public Affairs Committee and Legislative Affairs Committee in Washington State Psychiatric Services, I'll toss out two things that I thought really helped. One is for the media, the way they work the best is that they're easy to get to. Because otherwise, they're always on a deadline, they always are waiting, they're writing it today, they call in the middle of writing their report. So having somebody has available report. Second thing is to line up your bullet points and your sound bites before you go into any interview or anything. Because they're gonna, and you wanna know exactly what you're saying and exactly how they might misinterpret it. They can always misinterpret what you say, but if you write it, if you say it in a way that they can't, that enhances your message. So you gotta write it up before, have it ready to go, because otherwise they will just do all kinds of odd things. They're trying to sell a newspaper, they're trying to sell TV time, and the more outrageous something is, the more they sell, the more people that get to read it.
Right.
So those are really important.
Yes.
So much what you're saying.
So, yeah.
We have a public relations person here, Susan Gregg, that many of you might know. She's always on the lookout. I mean, I get, Doug Zapsik and I, we're like the PTSD people. We get a couple times a week. And the question is, can you talk to so-and-so this afternoon? And I think if you're looking for a venue at some topic that's important in behavioral health, you let Susan know, because she can get that all going, because that's her area of
Yes.
expertise. And I think she mostly finds people say no.
Don't forget to fill out the
Mhm.
comments. Don't forget, there's papers, it's important.
Yes, thank you for that reminder. So yeah, a few takeaways for anyone joining on the phone. To be available to the media and be findable, right, through the internet and so forth, and be prepared and anticipate any interpretations that are not what you want to, be the message from your research. And then also, I agree, our UW media relations folks, including Susan Gregg and Bobby Nodell, I've worked with a lot, such an incredible resource locally. And then we have our professional licensing boards, our academic professional societies are also really valuable too. So thank you.
Sources you mentioned and Aaron mentioned, the Wall Street Journal is actually a really good source. They do great graphics. They are always on top of stuff important because people want to make money off of it. But they do a fantastic job searching out what's going on. Again, they have their own twist on it. As long as you understand their twist,
Yeah.
you can interpret it. But it's a very useful source.
Yes. Thank you so much. Thanks everybody for joining, and take care. Thank you.
Of course. They got their angles.